Well, thank you everyone for attending and being a part of this today. We are going to go over how CCS came to be and kind of how it's working in St. Croix County. We will share some of the things that we are looking at moving into the future as we go along. So some of the information we share today, just know is going to change a little bit probably in the coming year, especially after we get past our pandemic time now. So let's go to the next slide. And like I said, welcome. We'll move on. So today what we're going to do is roughly we'll talk for hour and a half on the overview. I think it's important that we all get a little break and get up and move around. If you're at home, and well, yes, you are at home, I hope, and you need to just get up and move around, please do so. Again, just keep everything on mute so that we can reduce as much of that echo and background noise as we can. And then we'll try to do a little break between 10:30-ish, 10:40, and then we'll finish up after 10:40. Let's move on. So CCS, the state of Wisconsin is famous for having lots of C's in their various programs. And what CCS stands for is Comprehensive Community Services. The idea behind CCS is that it's trying to fit us in a place where we can work with folk who don't need hospitalizations or don't need inpatient settings, such as Winnebago, but really aren't doing as well as they could, and they're not being very successful in an outpatient type setting where it's just going to therapy once a week. So these are folks who are kind of struggling with mental health or addiction issues in between, and they kind of fall in between these two areas. And so, probably in the early 2000s, Wisconsin started to look at other options, and it was getting pushed definitely around by the federal governments as well about we need to try to find something to help folks with these difficulties and try to how do we help them have a service that's really going to work for them. And so CCS kind of came out of these thoughts. Let's go to the next slide. When they developed CCS, the whole idea was about psychosocial rehabilitation. And the idea behind this, is like I already talked about a little bit, was really about what is that person's, that we call it in St. Croix County, service recipients' goals for their recovery. And so, as you all know, those who have been a part of CCS, it's really recipient-driven. So we're working with the recipient to help them with their goals, what they need for recovery. And so the fancy term is psychosocial rehabilitation services. And so anything that we're doing in CCS, anything that we are offering service-wise, really has to be focused on that psychosocial rehabilitation. So CCS, folks, is a lot about teaching skills and helping people develop skills so that eventually they're ready to take the ball and run with it. It isn't, it's different than some other C services in St. Croix County or in Wisconsin. Whoa. A little reverb there. That in St. Croix County or in state of Wisconsin that looks at things on a grander scale. So let's see here. Let's go to the next slide. So as you can see, there's an awful lot of different C's within services that are offered in the state of Wisconsin. So CSP is the Community Support Program. For those that may not know, that is a program that is was developed, and it's been a part of Wisconsin's group of services for many, many years. I've worked for the county now for 22 years, and it was here long before I ever showed up, so I'm guessing it's been around, maybe 30, 40 years. CSP, the idea behind CSP, Community Support Program, is that it's for chronic mental health, people with chronic mental health issues. It used to be, and they've loosened this up a bit, but it used to be for folks who had schizophrenia or diagnosis of schizophrenia, bipolar disorder, or major depression. It's been loosened up a little bit to allow, but the idea behind CSP is that it's there to aid folk probably till as long as they ever need it, even if they are in recovery, so that they have services that allow them to function in society even with these severe mental health issues. And then you can see we go on and on. Community recovery services, again, very similar in terms to CSP, slightly different. Child Protective Services is another program, CPS, that if there's a report of child abuse or child maltreatment, Child Protective Services goes and checks to see does an investigation, and then if interventions are warranted, they are part of that. Coordinated service teams and coordinated family services was kind of the forebearer to CCS. It was often done in a very much in the same vein as we do in CCS with teaming, but it was run through programming that often came out of the children's services world. And if a child or a family was involved with children's services, either through juvenile justice, et cetera, they could be referred to the coordinated family services, and then a wraparound team could be a part of that. CLTS, basically that is child's long-term support, or what we know as waiver. And waiver is another state program, federal program, that's funded by MA, that is there to help youth that might have problems with autism or developmental disabilities, but they also have a social and emotional disability part to the waiver as well. And some of our children, some of the youth that we work with in CCS also are involved in the waiver program, and so they kind of are in dual programs. So as you can see, Wisconsin has kind of this lot of different programs, and unfortunately, they all have C's in them, so they can get a little confusing for all of us. Let's go to the next slide. Now, I had said psychosocial rehabilitation earlier, and this is kind of the key piece that we start to think about CCS that we need to remember when we're working with teams. Excuse me. When we talk about psychosocial rehabilitation, we're talking about how the recipient moves towards their recovery and achieving, and you can see it says on there, achieving their highest possible level of functioning and stability and independence. So any goal, anything that we are offering, any service that we are offering through our CCS and through our teaming, needs to make sure that it is addressing a recipient's ability for psychosocial rehabilitation. Is that service helping them learn a skill that's going to help them towards their recovery? And then, as again, many of you know, we have mental health professionals and substance use professionals who are on teams, and their job within CCS is to review those services and decide, are those services meeting that psychosocial rehabilitation? And are they being done at a level that's needed for that? So sometimes our MHPs have to look at how those services are being given, and are they being given? Are there not enough hours? Are there too many hours? Are there is that even the right service? Should that even be? Is that making sense given the goal? And so their job within CCS, as the state has defined it, is to kind of be that person who's overseeing what's going on. And sometimes the mental health and substance use professional can also give suggestions to teams. Again, CCS allows for this person-centered mental health and substance use treatment program that gives us some flexibility. So it allows us to use some non-traditional ways to help folk. When I say non-traditional, I'm talking about not just your inpatient kind of service or outpatient service such as going to see a therapist, but it also includes us with ways to use other skills. So if someone was struggling with anxiety, they certainly could use yoga skills as a way to calm themselves, to calm their body, which then we know allows our brain to calm, which then allows the anxiety to drop. So then that's how we would say yoga would make good sense to be used in this case, if that worked for the recipient and that was the recipient wanting to pursue that. Again, the idea is that we're providing a service that the recipient learns from, so that they can take those skills and then put them into their life. It isn't that we do for the recipient. It's teaching a recipient so that they can then move forward with those skills. Let's go to the next slide. So as CCS was developed, and it was talked about back in the early 2000s, I attended a number of trainings that the state was putting on for as they were kind of rolling CCS out. And one of the important pieces they always said is it was very person-centered. And so they wanted this to be about folks' recovery. And that recovery as the recipient defines it. So we as professionals may say, they want to really address certain, we think, oh, that's the area they should address. Well, the recipient may not be ready to go there yet. And so we meet them where they're at and help them to promote that recovery. We also want to match the services to their recipients' needs to the appropriate services. So we kind of went over that earlier, but it isn't just throwing everything at them. It's being targeted as what we need to do and not trying to overwhelm a recipient either. So we want to make sure that as we are offering these services, kind of doing them in a way that makes some sense for what the recipient needs and at the same time isn't becoming overwhelming. And finally, we want to promote collaboration across systems. So the idea behind CCS was and is a lot of that teaming piece. And so what we always hope for is that we can bring all the different systems that a recipient might be involved in. So if in youth cases, sometimes besides the providers, we also try to invite schools to be a part of it. We may, if we're lucky enough, we may be able to get doctors or nurses, or on some teams that I was involved with, we're able to get like the psychiatric nurse to come and be a part of the team when that recipient was needing psychiatric medication, was seeing the psychiatrist. Well, the psychiatrist wasn't going to be a part of the team, but the psychiatric nurse came in the place of the psychiatrist and represented that part. So again, it's how do we collaborate those the work that we're all doing amongst ourselves. How do we collaborate and how do we coordinate that work so it makes sense? And again, we're not overwhelming our recipient, but also helping them to learn those skills to move forward. Let's go to the next one. Obviously, we're doing CCS because we want to reduce, and any of our services, we want to reduce the impact of our mental health problems and our substance use problems on the recipient's life. And again, to attain the best level of functioning, stability, of independence for the service recipient. So if you think about that, and we think about what I've said earlier, the service recipient still is the one who's going to tell us where their line is for what is the best level of functioning. And this is really key for CCS, is that we may have ideas, and we can certainly present those ideas in our teaming about what we believe would make sense to help someone move forward and have recovery. But ultimately, it's that recipient who gets to make the decision. And so some folks kind of can have episodic episodes of CCS treatment. So they might come in for a while, work with us as teams, and then say, well, yeah, I've got it as far as I want. I'm ready to go try some things. And then they may find that they need kind of to come back, and that's okay. That's part of CCS. So if we talk about best level of functioning, it's the recipient who gets to define it. We can share our ideas, but ultimately they get to make that call. Let's go to the next one. The philosophy behind CCS. The whole idea behind CCS has always been that recovery is attainable. That whether a person has mental health or addiction issues, that if they get enough support around them and develop enough natural supports around them, that eventually recovery can happen. And the idea behind CCS is that they want that recovery to happen while a person is in their life, in their community, and lives where they're going to live. So when we talk about CCS, when we talk about our teaming, when we talk about doing that in the community, the idea behind it isn't just all of us as providers, but also bringing in those natural supports, because those are the people and those are the supports that are going to be there when we as the providers have moved on, because they have the ball and they're running with it. That the recipient is ready to go try things on their own, though they're going to still need some of those supports around them. But those supports, we hope, will come from those natural places. So again, our philosophy is that it's attainable, that recovery is attainable, and that you can do this, but you need, we all need some help, and it's okay. Let's go to the next slide. So the core values of CCS as a program really have centered around, and I've kind of hammered away at this already, a person-centeredness and being recovery-focused. Another one that's really important is strength-based. And so when we think about strength-based, we think about trying to find what does this person that we're working with do well, and how can we build off of that? So often in the medical model of treatment, it's always been a deficit base. And so deficit base is, well, what's going wrong in this person's life and how do we fix it? Well, that, if you think about that, we're not, this isn't like a car and we're taking it into the shop and we're going to change out the starter because the car isn't starting well anymore. What we need to do is really with folk is that we find what it is that they do well. What are they doing well in their life? I mean, life isn't, even those folks struggling with mental health and addiction issues, there are areas that they are functioning well in. And what are those strengths that they have, and how can we help them use those strengths to move towards recovery? So it's really strengths-based, and it's trying to find a way to use strengths-based language to be able to share with our recipients what we see them doing well. So it isn't just always praising them, but it's also sometimes helping them reframe what's going on in their life. So an example, the other day I was working with somebody, and they kept telling me that they were stubborn. And what I said is, I said, you sound like you're a very determined person. And then for them, that was like, oh, yeah. Oh, I see what you're saying. I've got that as a strength. You've got a lot of determination, and that really is what we look to do. So as you work with folk, or you think about folk, think about how you could share what you're seeing in a way that's strengths-based, because that's really one of our core values. Obviously, we've already talked a little bit about that collaboration across systems. Again, CCS is team-based. We're trying to help folks have this wrap around them and bring in natural supports as well as kind of those of us who are our providers. Goal and outcome oriented. Anybody who's worked with St. Croix County's plans, we certainly know that our objectives need to be something that's measurable. So what are we moving towards? We have this goal. The goal is kind of that overarching piece of that kind of we talk about as the main thing we'd like to see happen. But then how are we going to know that that's going to happen? Well, we need to know what the outcome is. So if it is, I want to be less anxious, or I want to have friends, well, how are we going to know that you're doing that? And that's where we get into those objectives and we measure, because that's going to tell us if you've made progress. And so the idea is that as we write up our plans and with our core values, is that we're really trying to help the recipients and the team stay focused on not only what the goal is, but also what's the outcome? How do we measure that so that we know we're making that progress? Because as we can see progress, that allows people to have that belief in their growth. And as we practice helping them learn their skills and practice those skills, that's going to help that person with empowerment. So again, we want the recipient to feel like they're learning, they're in charge, and they are the ones growing, that we aren't doing it for them. They're the ones doing it. We're just there aiding them. Let's go to the next slide. Now, we'll kind of bounce around on this slide a little bit. I've talked a little bit around the building of natural supports within the community and the peer support natural support. So let's just kind of dive into that just a titch more. As I've said earlier, we certainly want those natural supports to be on our teams, and because eventually we as all the providers are going to be leaving. At some point, we have done our job well enough that we're no longer needed, because that's the goal of doing good work, that we've helped the recipient get to that place that they don't need us. That's, if we're doing that, we're doing some really good work. Now, part of that good work sometimes in CCS is that we involve people who are called peer support specialists. So other people who have lived that and walked that life sometimes also become part of our teams and aid our recipients in moving towards that. Sometimes it's easier if you've known somebody who's had to go through something much like you have, and they have some advice or some thoughts for you to think about. You know that, well, okay, they've made it through. Maybe I can make it through. So again, there's that piece of hope that we talked about in the previous slide. But there's also the idea that by including those natural supports and those peer supports in a recipient's life in CCS, that they can not only have the hope, but they can then move things forward in their life as part of that teaming. Meaningful participation, obviously, we want any recipient to be really involved. Again, it goes back to we're not doing for, we're helping them learn to do for themselves. And culturally relevant and comprehensive. Again, CCS talks about making sure that whatever we are offering to recipients meets them where they're at, and if they're at as a different culture than maybe where we have come from, we need to work with them in that way. Let's go to the next slide. as we do this, and you look at some of this, so cost effective. So remember I talked about MHPs a little bit earlier on SUPs, and that part of their job within CCS is to really look at plans and services and make sure that the hours and the service, et cetera, really fit with what's going on. That's part of that cost effectiveness. Quality improvement. Obviously, one of the things that we're always looking to do is to try to find ways to provide quality services, as well as, and we'll get into this later, making sure that it makes sense what services and what we are doing from the moment a person comes into service all the way to the end, through our documentation, through our planning, through our teaming. So we're always trying to improve. Flexible and creative. One of the things that is neat about CCS is that it allows us to use services that normally wouldn't have been paid for by MA. Example being non-traditional services. So a lot of folks, I know a lot of you who are online right now, do what we'd consider non-traditional services, services that in the past wouldn't have been paid for by MA for our recipients. And so through CCS, we can do that. And that allows us to have some creativity, allows us to be flexible. And, you know, with that said, MA still has its rules, and still has its little guidelines for us on either side of it, and we still have to stay within it. But those guidelines have gotten much greater within CCS than they used to be. And we talked about outcome-oriented, again, very much about how are we measuring this, what is the progress, how are we moving forward, how are we showing that we're moving forward, and using the resources that we have available. Let's go to the next slide. So CCS has been adopted by a lot of counties across Wisconsin. As of 2014, this is the blue is all the counties that were using CCS. And I don't know, Adam, do you know if of these other ones, have they joined? Is all of Wisconsin now CCS, or do we still have some that are not?
The only county on this map that has joined recently is Burnett. They just joined the WRWC as of January 1st.
All right. So we've taken one more off of the map. But as you can see, it's pretty widespread across St. Croix County, or across Wisconsin. And St. Croix County, well, let's go to the next slide before I jump into that. I was going to get ahead of myself. So St. Croix County has joined with two other counties, Eau Claire and Barron, and we do a shared services model. And doing a shared services model means that each county still has kind of their own individual way of doing it, but we share our resources with one another, and we can share expenses with one another. A perfect example of this is Adam is helping us today. Adam is our project specialist for Barron, Eau Claire, and St. Croix County. So Adam moves really between three counties, working with all of them on training issues, quality improvement issues. Well, Adam, why don't you speak to what you're doing a little bit right now so people can get a sense of who you are and what you're doing for us in this shared services model.
Sure. So my role, I kind of see it as two main parts. My primary role is to work with the three counties as a region and help with things that we want to accomplish as a group, sharing best practices. I'm a liaison. I'm a communications through line. If people have questions for one county or the other, they'll probably reach out to me to find out the answer. I'm also a liaison with the state and some of our surrounding regions and counties. I've worked with the WRIC, which is La Crosse, La Crosse, Monroe, and Jackson, I think, is the county. And then the WRWC, which is pretty much all the surrounding counties from where we are right now. The other half of my role is I do individual projects as well for each of the counties. I'm a non-clinical resource in that I do a little bit of everything. I'm here today to help with trainings and technology, and I also do a lot of project management and data analysis, and I'm kind of the regulatory and policy guru sometimes in the room. So yeah, I end up doing a lot of things, but I think that's a really good example of the shared services model, is this idea that we are 3 individually certified programs and we're completely autonomous from each other, but we're making an effort to share resources and share best practices and really be as unified as we can in providing a quality, consistent program for the folks that are in need.
Thanks, Adam. And so the other thing you probably see there is that Eau Claire and St. Croix are using the same electronic health record. And so it's called Avatar. And what we do with that is we kind of, even though we're each separate, we learn from one another on how we can best use Avatar. And Adam is also very helpful for us and Eau Claire with that, as we try to write reports and find ways to improve the program through the data that we can gather through that. Let's go to the next slide. So one of the things we do with our regional CCS, obviously we all have to remain in compliance with known as 36. It's how Wisconsin wrote up CCS. They're basically the rules. So Adam said earlier that he's kind of our guru around that. Yep, he's the guy that has read that. We go to him, we talk to him about those things, and we'll say, sometimes we end up having to go back to the state to say, can you kind of clarify what you were saying here? Because some parts of 36 are rather ambiguous. We also use our functional screen, and as maybe you know or don't you know, that because this is a state of Wisconsin program, as recipients go to enter into this program, they still have to go through what is known as the functional screen. And so the functional screen asks a number of questions of recipients, and the person screening with them then fills out this functional screen. We send it into the state electronically, and then it kicks back to us what services a recipient is eligible for. And so sometimes we think somebody is a slam dunk for CCS, and I'll be quite honest with you, the functional screen comes back no. And we get a little confused as to why. Those functional screens then need to be done on an annual basis. So somebody may be in CCS, may progress well enough along that when we run the functional screen a year later, they're not eligible anymore. And that's part of the state's way of kind of also keeping tabs on who can get in and who can't. We use surveys. We use surveys of the Rosie and the MISHIP once a year. Each county is working on ways to get that out kind of throughout the year to make sure that we're gathering that data. We also are looking at other ways of gathering data from working with our teams and working with recipients. Another thing that the state does is we call it PPS, and I don't even know what it stands for anymore, but it basically is gathering data of who's getting into the system, what is it they're coming in for, and then as they graduate, what was the progress that they've made. So let's go to the next slide. So who's eligible? In St. Croix County, to be eligible for St. Croix County CCS, you have to be a county resident. So you have to have established residency in St. Croix County. So there are certain areas where a person does not establish residency. So if someone was driving through on 94 and got into our mental health system because they did something that got them hospitalized, but they live in Milwaukee, just because they got hospitalized in St. Croix County doesn't make them a county resident. It just means that they were hospitalized here. So they couldn't receive CCS services from St. Croix County. If somebody moved from the Twin Cities, and unfortunately they're homeless, and so they moved to they moved to Grace Place in New Richmond, which is a homeless shelter, they aren't considered a St. Croix County resident at that point, because a homeless shelter is under county rules is not considered a residency, a permanent residency. Now, if they move from the shelter to an apartment or planned on it, then we would work at serving them. So they have to be a county resident. They have to be able to have some goals. Are their goals appropriate for CCS? We have some people who look to get into CCS because they don't have any housing. They don't have any other goal. They just want housing. Unfortunately, that's not a rehabilitation goal for CCS. We can certainly give them ideas of where they can go to get housing, but CCS would be not an appropriate program for them. Functional eligibility, obviously, I already talked about the functional screen a little bit. We know that they have to pass that. We have to show that what they need is really beyond what an outpatient service can handle, and that they have a diagnosis that's either a mental health diagnosis or substance use diagnosis. And if somebody appears to be appropriate for CCS and has never had a diagnosis, we work with them to try to find a way to help them get to see somebody who can get them a diagnosis so that we can work to get them into CCS. The other key piece to St. Croix County CCS is that they need to have MA. So if a recipient was referred to our program and they don't have medical assistance, maybe because the family has private insurance and does not qualify for MA, then they would not be able to be in our CCS program. If they did qualify, let's say they came in with private insurance and they qualified for MA, then as long as they could get MA, they could be a part of CCS in St. Croix County. Let's go to the next slide. So to get into CCS, the process is, one, you get a referral. So anyone can refer themselves. This is key. If I called up and said, oh, I've worked with Tom who I think needs to be in CCS, that's great, but Tom really still has to be, Tom is his own person. Tom's over 18. Tom is his own person. He still has to call in and ask for that service. Okay? If a parent of a youth were to call in and ask for CCS, that's fine. That's a way to make a referral. But again, a person in CCS has to be, they have to ask for it. They have to self-refer. You cannot be forced into CCS. So that referral has to come from the recipient or the recipient's family if they're a youth. We talked about the functional screen. Then we start getting into, they pass the functional screen. Let's get into this. They pass the functional screen, then the recipient and the service facilitator that gets assigned will do what they call a number of different, well, we just call it a number of different forms. In our lingo, we call it the 4 forms. But it's 4 different forms that allow them to say, yes, I'm going to be a part of CCS. They then get those forms, get passed on to an MHP who reviews and signs off on them, and now the clock starts ticking, because once those forms are signed, you now have 30 days to get your comprehensive assessment completed and have your initial recovery team meeting and have developed your recovery plan. That's a lot to be done in 30 days. And so any recipient really is now kind of in this very intense time working with their service facilitator to get everything focused up and get ready to start talking about what are we going to do to help that recovery moving forward. That initial team meeting sometimes doesn't include a number of you as providers, because sometimes the recipient isn't sure quite yet what they want, and so that initial team meeting can sometimes just be about getting those initial goals down and talking about what they're willing to work with or try what services they're willing to try to help them move forward in their recovery. Let's go to the next slide. So let's do our roles within CCS. So, and as we go through this, I want you to realize that it was St. Croix County CCS. Let me give you a little bit of data before we dive into all our different roles. So St. Croix County CCS, when it was established in 2016, was set up to kind of work in two units. And so in St. Croix County, we have the behavioral health unit, and we have the children's services unit, and we have public health, and we have a number of different parts to our health and human services. So in St. Croix County, the way we have it set up is that we have part of our administrative team is within the children's services unit, and part of our administrative team is within the behavioral health unit. And so the children's services is focused mostly on working with our youth and youth programming, and our behavioral health unit has worked mainly with the adults. Now, what is going to be changing this year in our CCS program is that it was passed by our budget and okayed by the county board that CCS is going to become its own unit in health and human services. So CCS is going to have its own new administrator. I'm going to remain as the service director, and we're talking about then how we're structuring things from there. So as we talk about our different responsibilities, we'll talk about them with the idea that some of this could be changing as we move forward, but this really is where we are at right now. And as we move forward, if things change, we obviously will let people know, and we'll kind of, especially responsibilities, and we'll let people know as we move on in this year. But as we know, that with this kind of unusual time in our lives of our social distancing and staying home and not having human contact, it's going to slow that process up just a bit. So let's go to those responsibilities. Let's start with the administrator. So the administrator is ultimately the person in charge. Sorry, I had to get a drink of water there. I'm getting dry from talking. Our administrator is the person who's overall responsible for CCS. They're kind of the person who oversees our collaboration. They provide the support and the guidance and for the administration of the program. They often do some outreach to our CCS into the community, often kind of along with myself as the service director. So this is what we've done in the past is what some of our administrators have done the contracting with your various agencies, and not so much the service director has been doing the contracting anymore as much as other administrators have. And then they provide our administrative supervision. So the administrator is kind of the head of our program. Let's go to the next one. Then we have the service director. Under the way the 36 was written, the service director is really the person who's responsible for the clinical part of CCS, as well as the quality assurance and kind of that day-to-day consultation with CCS staff and mental health professionals, substance use professionals. The service director provides the clinical supervision for the MHPs and often does the backup MHP work for service facilitators if another MHP is unavailable. I'm kind of that, as the service director, I'm your central contact for the day-to-day operations. As many of you have experienced, as we've kind of waited for MA to give us the guidelines of what we're going to do during this public health crisis. I've been kind of that point person, and that's my responsibility to help you. The other part of my job is definitely quality assurance, and so a number of you may have worked with me or in the past as I've worked with providers. I'm making sure that your notes meet the requirements that we have to have, as well as I work behind the scenes with Adam, with our medical records unit, on making sure our records meet the quality assurance standards that we need. And I also work with, and again, many of you may have had some contact with Carol and Lindsay now, who are folk who do 100% of auditing of all our notes. And so when they have questions on those notes that are coming in, and especially around the clinical aspects of those notes, then they reach out to me, and that's when I help on that piece. So part of the service director job is definitely around a quality assurance of our program to make sure that we are providing in St. Croix County a program that is meeting all the standards, as well as maybe hopefully exceeding them sometimes. Obviously, I also assist with our portal management and training. And again, I'll give a tip of the cap to Carol, who does a fantastic job, and Adam, who both do a fantastic job of helping me with keeping that going. And I work with a lot of our providers. So if they have questions, the service director's job is to kind of reach out and answer questions as best as I can, or at least try to find us those answers. So I'm kind of as a service director, you're kind of the hub of where everything flows out of, and you try to do your best to keep this program moving forward as efficiently and as well as it can. So let's move on to the next guy. Financial staff. So our financial staff, and I mentioned earlier, our accounts receivable, I had mentioned Carol and Lindsay, who do a lot of checking of the notes and going over your invoices as they come in. We also have financial staff who, Jane Hansen, who's now in charge of that part around our contracting and setting rates with contracts. Some of that is guided through what the state will allow, and so that's where we get kind of right at that line of what we can do. Carol and Lindsay always go into our portal. They are the ones who are making sure now that we get our service authorizations out there for all of you to have. And they're working with our service facilitators to make sure that our plans are out there on a timely manner, so that all of our providers can see plans if they need to that they're on. Carol and Lindsay will go over your authorizations to make sure that the notes and the amount that you're billing meets the authorizations, so you're not going over. They're going to do our 100% review of our notes. They're doing the billing piece. Our financial staff also does this, what we call annual cost reconciliation. And so what happens with that is that MA pays a certain point, and then we also can reconcile some of those other areas that aren't just direct bill, but are billed to CCS. So there are certain things within a service facilitator's time that may not get captured as a direct billable time for CCS, but still falls under what CCS pays for. And then you can do that annually and bill MA for that. They also aid in that budgeting and forecasting, and so that forecasting is also a piece that Adam does with us in trying to determine how our program will grow and how do we see our population growth within the program, meaning what we need to do in hiring people moving forward. Let's go to the next one. And service facilitators, and I think the majority of the folks online probably today have worked with our service facilitators. And service facilitators, the way we do it in St. Croix County, really are the kind of that frontline professional who works directly with the recipient. They do the planning. They make sure that the work is integrated and that it's coordinated, and that plan as it's written and is making sense. They're working with their MHP as they kind of clinically work with the family or the youth or the adult on moving forward. They build that relationship with the folks that they're working with. And I would say St. Croix County is very lucky to have the service facilitators we do. They've done an excellent job, and I'm going to just take a moment and brag that I think that one of the things that we've heard from the state in previous audits is that St. Croix County does CCS as it was intended, and I think a lot of that goes to our service facilitators. So as you work with them, sometimes we don't always see eye to eye, but I think our facilitators do a fantastic job of working with our teams and helping them to kind of monitor what's going on and aid our recipients with a chance towards their recovery. So they have a lot of responsibilities. There's a lot of paperwork that goes into CCS. CCS was not developed as a very lean program. And our facilitators are responsible for all of that paperwork. Part of our QA process is to aid them to make sure if things are not quite where they need to be, to help them get them where they need to be. And so we have a lot of backups for our facilitators to make sure that they are, aren't just kind of having to fly out there on their own, but they do an excellent job for us. And that's what our facilitators do. So let's go to the next one. MHPs. So we talked a little bit about the mental health professional. So the mental health professional, as you can see in that write-up, the mental health professional shall do the following. And so when it says review and attest to the applicant's need for psychosocial rehabilitation services and medical and supportive activities to address the desired recovery goals, et cetera, right? So what we have going on there is really the MHP is the state's way of having that set of eyes on site that is signing off and saying, yes, this person needs services. Yes, these services are appropriate. Yes, the amount of hours that are on this plan are appropriate for that recovery. So anytime that there is a question, the mental health professional really is the one who's attesting to the state that this is appropriate. And so when we're audited, they certainly are the ones who will have to make sure that whatever they have signed really does make sense, whether we're being audited by the Department of Quality Assurance or by MA. that whatever they sign off on really is going to be appropriate for that. They also provide clinical supervision for our service facilitators and sign off on authorization of needs, service plans, and discharges. So as people are graduating, our mental health professionals sign off on that as well. Let's go to the next one. Substance use professional is basically the same thing as a mental health professional, except their focus is completely on folks with addiction issues. So folks, if a recipient has an addiction issue, the way that it's written into the rules is that a substance use professional is to review and see if this person or recipient needs to have further assessment to see if treatment is recommended. They also then will need to sign off on service plans if there are addiction issues. They also sign off on authorization of the needs, again, if there is an addiction issue identified. And they'll sign off on discharges as well, again, when there's substance use addiction identified. And they will perform the assessment. So what happens is that if a recipient has substance use identified, and within that first 30 days, this would be another person who would need to have an assessment done because their addiction leads to that or is at a level that the substance use professional thinks that an assessment is done, then the substance use professional performs that assessment. Let's go to the next person. Peer specialist. So our peer support specialists in St. Croix County are, the way they work within CCS is that they are hired by other agencies and then can be brought into teams. Peer support specialists, as stated earlier, are there because they've kind of walked that walk, and they're there to offer support and hope and suggestions to those who are also now struggling with that mental health or substance use issue. So because they've been through this before, they often can help kind of people figure out how to get through things, how to use this, how to get through the various systems that they might have to talk to them about what it's like to be in a hospital, etc. Things that some of us probably don't have any clue of or have never really experienced in our own lives. And so in many ways, it's much like you would have with AA or NA systems where you've lived that life, and so now you're offering that information to them. Peer support specialists need to be certified by the state of Wisconsin. They have training programs that they go through, and that would allow them then to become certified peer support specialists. Let's go to the next one. We have a coordinating committee, and this is part of the rules of 36, is that each county that has CCS has a CCS coordinating committee, and they have oversight and direction for the program. And so on that coordinating committee, you will have, can be service recipients, and it can be people with lived experience, and it can be providers, and it can be staff. And it really talks about how and guides our program, how it's going to move forward, and make suggestions to administration about what they see is needed to help the CCS program move forward. They help in developing role policies and procedures. They have ideas around quality assurance. So they're kind of this outside group that helps us move forward with CCS. Let's go to the next slide. So we have for orientation and training is Chapter 36 requires that if you have less, as you're a provider now, and you have less than 6 months experience, we need 40 hours of CCS training within the 3 months of your hire. So what we have on our SharePoint site is the ability to offer these 40 hours in services and various trainings, and you'll see that there's lots of different ways one can gain those training hours. Now, if you have more than 6 months of experience, then it's 20 hours within the first 3 months of your hire. And if you're a volunteer, it's 40 hours if providing direct service to service recipients. So this is true for not only providers, but for any staff that we hire as well, that you need to have your hours done. So when I was hired as the service director, because I had more than 6 months of experience, I still had to get in my 20 hours of CCS training within those first 3 months of my hire. Then our ongoing requirements for CCS is 8 hours of CCS training, services training a year, and then you document that. And that's all part of what you would turn into your agency, and they would upload it into our portal. It's the same thing for all of our staff. They're required, myself included, required to do 8 hours of CCS training a year. Next slide. So it's more than just meeting our training requirements, obviously, because we want to have this professional growth. We want to be able to learn as we go. And sometimes as our populations change and become different, it allows us to gain some new skills. So training is really more than just meeting the requirements of CCS. We can use it in a way that it can help us grow as providers and people working with our recipients. So let's move on. Some of you, or maybe all of you, have had some access to our CCS portal. With our portal right now, Carol is the one who, Carol Peterson is the one who's kind of in charge of that. We will offer training on how to get in and use the portal. As you know, we need to send out an email with an authorization. You click on it, you get in, then you get into being a part of the portal. I'm assuming, I'm hoping all of you are a part of that and are able to then see on that portal, there's what are we doing, updates, training opportunities, etc., as well as depending on how your agency chooses to do it, you would then upload your notes and billing into that portal as well. We'll go to the next slide. Okay, so referral application and screen. We touched a little bit on this, so we'll kind of move through it. Let's go. So as I said earlier, we have two different units right now that kind of are in charge of our CCS program. So because of that, youth come in through the Children's Services Unit and adults come in through the Behavioral Health Unit. So on the youth side, you would have that centralized intake for youth. Just much like we would on the adult side, we'd have this centralized intake for our adults. The referral is reviewed and assigned to a social worker on the youth side. That social worker will then go on to meet with, social worker / service facilitator will go on to meet with the youth or family and do the assessment and determine which services may best need. So remember, we're back doing our functional screen at that point. And then they're going to aid them. If they pass the functional screen, they'll aid them with getting involved into doing the CCS forms to get them into CCS. On the adult side, it's very much it's similar in that, again, they'll go through a centralized intake. In that centralized intake, they're going to call it a level 1. Basically, it's a telephone interview. In that telephone interview, if CCS is what they're really calling in for, it's going to be taken to an access team, which is a team of various professionals from lots of different parts of our behavioral health unit. So you'll have not only CCS sitting in on it, you'll have you'll have an outpatient services person there, you'll have an adult protective services, you'll have emergency services, you'll have addiction services, all on that team working to figure out what's best and make recommendations. But then if we get to our CCS part, then we move on to making sure that that is, fits the most appropriate need. Often it's then transferred to me as a service director to get it assigned to somebody so that we can do a follow-up, much like we would do on the youth side. But again, the most important part of this slide is that right now our youth come in through children's services and our adults come in through behavioral health. Let's go to the next slide. So this is a kind of an important slide. So in terms of our assessment process, as we kind of just went over, which might include substance use or assessment if that's indicated. We then go from that assessment process. So if you go back and you think about this, I talked about how they do their 4 forms, then they do this comprehensive assessment. They do, based on that comprehensive assessment, so they're looking at all areas of recipient's life. Based on that information, that a recovery plan is then developed. So what is it the recipient wants to work on? And it's based on this information that was gathered through this comprehensive assessment. We get to this recovery plan. That recovery plan then drives what services would be most effective for psychosocial rehabilitation. So if I'm looking at those services, I should be able to go all the way back to that assessment, that comprehensive assessment, and see that is what is indicated. That's really what's needed because it shows up in that comprehensive assessment. So those services that are being offered make sense. Then as you're providing, any of us are providing those services, we're doing a progress note. Because we do that progress note, it should indicate in our note, and we'll talk about this afternoon, how that service is making sense for meeting the goals of that recovery plan, which I could go all the way back to that comprehensive assessment and make sense. So if I were to do, they call this the golden thread, but if I were to do this golden thread through your progress note or my progress note back to the services that are being provided, back to that recovery plan, back to that comprehensive assessment, it all should make sense. And so our foundation for CCS is really that all of this is interconnected, and it makes total sense if you were to pick up a chart and see why we're doing what we're doing. Let's go to the next slide. So we talked a little bit about this, but within that first 30 days, we have an assessment process. The assessment summary is completed. If there's substance abuse that assessment needs to be done, that's completed. The written service plan gets, or the recovery plan is done. Keep going. Next slide. And then that recovery team gets developed. So let's go on. So with our recovery teams, if we think about that, our recovery teams, and a number of you have been on recovery teams already, the service recipient is the driver. They're the person in charge. So they're the one in the middle of this slide. And those surrounding them, remember, we think about our teams as kind of a wraparound program. You'd have your informal supports, maybe your peer specialist or an advocate. You'd have the various service providers, like many of you are on teams. We might have a substance use professional and a mental health professional, as well as that service facilitator who's kind of the person wrapping around all of it and trying to organize how we're doing things and helping things move forward. Important piece to this graph is to recognize that any member of this on this graph can ask for a team meeting at any time. So service facilitators are often the ones organizing our team meetings, but if a provider were to say, oh, I'm running into some issues, they could contact that service facilitator and say, I think we need to meet as a team. If that mental health professional in supervision of the service facilitator said, wow, I think we should meet as a team, anyone in there has the ability to call a team meeting. Even this, and definitely the service recipient can say, things aren't going the way I'd like. Can we meet as a team to try to figure this out? So your recovery team, though we kind of draw it in this graph, everybody is an equal player and everybody is looking to work together to help that recipient in the middle towards their recovery goals. Let's go to the next slide. So recovery team memberships can be obviously their service recipient, if it's a youth, their parent or legal guardian, service facilitator, recipients' natural support systems. So people can always invite other members to the team that aren't professionals. We've had people invite their clergy. We've had people invite aunts and uncles. We've had people invite their best friend. The mental health professional is there for the initial and is required to be there for the initial and at least once every 6 months for the reviews. Substance use professionals is required. So teams can have lots of different members. Next slide. And so if we look at our responsibilities, we need to, at a minimum, meet once every 6 months. Often, early on, we should be meeting more than that, but the 36 says you have to meet at least once every 6 months to review progress and update the plan. If a plan needs a change, if hours need to be increased, hours need to be decreased, a service is being removed from the plan, then the team needs to meet because that needs to be a team agreement and needs to be signed off on by the team. So that would mean teams would need to meet more often. Our role, obviously, as a team member is to then meet and then be a participant in how this is getting developed and how we're moving forward and monitoring our progress, and to provide that information. So as a provider or as a facilitator, you're sharing how you're, or as a recipient, you're sharing how you're seeing things going and what do we need to do to keep things moving forward in our recovery. What's working, what isn't, how do we make changes? And that's all part of our responsibilities as team members as we move forward in helping, again, our recipient towards the recovery. So we all have our responsibilities to the team. Next slide. We talked a little bit about this on that past slide about tying things together, but as we create a recovery plan, we go back to our assessment, our comprehensive assessment. So that plan needs to be based on that comprehensive assessment and those needs. The plan is a written plan. It's written for the plan for the services. It has those specific goals. It has measurable outcomes. So if we were to think about how we're going to measure the progress on that goal, we should have a behavioral outcome that kind of says, well, this is, I can measure this. I can see that this person goes out with their friends now 3 days a night or 3 times a month when they used to not do it at all. However we want to measure it, but it needs to be something that we can measure. And we have in creating this recovery plan, the whole team needs to agree. So we find agreement on that plan. So let's go to the next slide. So as we're doing the service planning and delivery, as our team, we're authorizing, and as a plan, we're authorizing services. And again, remember the MHP still has to agree to it and sign off on it. The services are provided are specific to the identified outcomes of the recovery plan. So again, if you think back to, if I read a note from a provider, it should make sense as to the work that's being done because it's meeting a certain goal for that recipient and the goal that that provider is working on. So any services provided within that plan should make sense to why we're doing it, and should make be attached to that goal in a way that it shows psychosocial rehabilitation. And then obviously as a team, we're doing this ongoing monitoring and oversight of the recovery plan, and trying to make sure that that is being moved forward and being done in a way that makes psychosocial rehabilitation sense. Next slide. So, crisis and CCS. So let's do this. Crisis services are not covered under CCS. So if somebody is needing to end up in a hospital because of a mental health crisis, CCS would not be paying for that hospitalization. Coordination of crisis services are covered. So as that service facilitator is helping that person write up a crisis plan or write up a crisis alert, or as the team is writing up a crisis plan or crisis alert, that is covered under CCS. Where we kind of cross over and work together, as I said earlier, we have the interdisciplinary team meetings in behavioral health. We have our access team that has crisis that sits on it, or our emergency services unit that sits on it, that works with CCS. We use the emergency services crisis alerts and crisis prevention plans. Again, we can use those as a clinical way to help people move forward, but also to kind of help our emergency workers in the field to know what to do if they were to run into needing to work with one of our recipients. And then any of our behavioral health crisis social workers do communicate with CCS. So let's go to the next slide. Discharge planning. How are we doing on time, gang? Let's plow ahead a little bit, and then we'll take a break for a few minutes. So let's go ahead. We'll take our break at 10:30. So let's do this discharge planning. The purpose of discharge planning is to help our recipients have a smooth transition from their kind of formal involvement to CCS to once they've attained their identified level of recovery and completion of programs. So our discharge planning really is around how do we move on from CCS to now being out on your own without all these formal supports around you. Now, if we've done CCS well, we've helped them have enough skills that they're ready to handle this on their own, and have enough supports around them from their life that they can kind of lean on those when they need it. So once a recipient has achieved their goals, or if they choose to just say, I'm done with CCS, we work towards that planning with the recipient and the team towards moving towards discharge. Again, sometimes discharges come to us when we don't expect it. Again, a functional screen sometimes comes up and says the person is no longer eligible for CCS. Then we start to have to work on a plan on how do we help them move on. Unfortunately, when a functional screen says someone is no longer eligible, then services all have to stop because MA will no longer pay for any services. But we as service facilitators in a CCS program will continue to work with that recipient towards their appropriate discharge and making sure that that transition is smooth as it can be. We'll go to the next slide. Our assessment, and you can see here's where this golden thread piece comes. Our assessment summary is interconnected with discharge because as we have gone all along, completed at admission, our assessment summaries are always updated. So every 6 months, your assessment summary is updated. And it should be gathering information as we go along, and it's basing that information on what it is that we need to do to kind of move us towards our ultimate goal of graduating, and assists, supports and provides the team with a direction developing the outcomes to be achieved that support transition and discharge. So again, based on that assessment summary and what we saw there, what it is that they are looking for, as we move towards this discharge or are doing our discharge, a lot of that information of what the recipient would want should be in that assessment summary. So again, it's that golden thread piece is really what we're talking about here, is that at any point we should be able to see the progress, we should be able to help people, we should, through any of our documentation, know how we're helping people get ready to be discharged and have moved to a place in their recovery that they can be discharged. Next goal, or next slide, please. After any recipient is discharged from CCS and or transitions to less intensive services, we still kind of check in with our recipients on a periodic basis to make sure, and that can be a part of that discharge plan. What I've seen in some of our plans is, we'll do a once-a-month check-in for the next 3 months to make sure the recipient is continuing to be stable with the gains that they've made. We'll go to the next slide. Let's take a break, everyone. It's almost 10:30. Let's get back together in about 10 minutes so everybody can go use the restroom or check your emails, and then we'll start up again at 10:40 to finish up our CCS 101 this morning. Thanks, everyone. I'll see you. We'll keep moving in about 10 minutes. Thanks. Well, hi everyone. It's 10:40, so I'm going to get us going again. Maybe before we go flying into the last bit of this, does anyone have questions? And Adam, what would be the best way that they could ask their questions?
I will let everyone pick. There is a chat function,
Okay.
which you can just type to everyone so that everyone can see the question, or you can individually unmute your line and ask your question verbally, but know that you might run over somebody.
Sure. So we could either do it through chat or unmute and ask me. Anybody have any questions about what we've covered so far? I don't think so. Okay.
And I would say if there are questions as we go, I do have the chat box open. So feel free to type in a question, and I'll either insert it into the conversation when we get there, or I will answer it myself in the chat.
Sure. Okay. Sounds like a plan. So the monitoring and documentation section that we're going to go into here right now, I'm not going to go too deep into it because a lot of this we're going to talk about this afternoon when we talk about doing notes, but just kind of to give you the concept. So we'll go to the next slide. So obviously we're doing our notes and our progress notes and for a lot of different reasons. We do them because obviously we need that program compliance. It is our mechanism for billing. It's important that we're showing the good work that all of you do. And another important piece, when you look at that last one, helps payers understand the services we're providing. As we'll talk about this more this afternoon, but in our documentation, we need to really be showing, why we're doing it, and so that when we say payers, we're really talking about MA, and an MA auditor were to come in and read your note, they should be able to go, oh, I know exactly why they're doing what they're doing and how it fits into that plan and how it helps that recipient or the recovery. So there's never a question of, what we're doing and why we're doing it. But so it's really important what we do with that documentation. And we'll get into that more this afternoon. So let's go to the next slide. Because CCS is 100% reimbursable through medical assistance, we have certain things that we just have to do with our notes and with our documentation. We need to make sure that because we are that enrolled provider, that we are following the rules of 36. That working with you all as providers, that you're following your responsibilities, your legal responsibilities. That the program, to the program and to the contractors, we are in charge of the fiscal responsibility of that CCS program, and we do get audited. So that's that is important. Why we do the work we do with all of you to make sure that we are in that program compliance. So let's go to the next slide. As many of you have experienced, there are a number of rules under 36 that for providers, and we need to have your background checks, your staff credentials, your records, your references, your licensing, your supervision logs, your orientation and training logs. some of your agencies may have been asking you to make sure that you have all of that information as and that it's downloaded into our portal, because we are audited, by the Department of Quality Assurance, and they make sure that we have all that information. And if we don't, that certainly can be a difficulty for us in that audit by the Department of Quality Assurance. Next slide. Obviously, with CCS, our records, 36 identifies how records should be kept. Our records really need to have enough information in them that it shows that CCS is appropriate, that our recipients have an understanding of what they're getting into, that we can show that we've talked to them about their needs, their outcomes. We have to show that there's progress towards those goals, or if there isn't progress, what are the barriers? When I've talked a little bit about the comprehensive assessment and then the assessment summary that is reviewed by the team and signed off by the team. Recovery plans that we've talked a little bit about. I know that many of you, when you've attended recovery team meetings, we've done attendance rosters that are required. We do authorization of service statements. If the consumer requests a change in a service from a service to service for providers, that all has to be documented. Pretty much anything and everything needs to be documented. It needs to be in that chart to be in compliance. Let's go to the next slide. So if you can see on this slide, you'll see that service delivery information needs to include, and this is all things that have to be in the chart, service provider and service facilitator notes. So when any of us are having interaction with our recipients, we need to be doing notes on that. Records of referrals from outside sources. So especially in the youth world, the others can make referrals for a family. We keep those records. Obviously, we still will contact that family to see if they're interested in being involved, but that record would be in their chart. Description of significant events that relate to the consumer and the quality of functioning. Obviously, it's a fancy way of saying we're going to keep tabs on what's going on and what are those events. And those events would be, in some cases, in our comprehensive assessment. Evidence of the consumer's progress. As we talked this afternoon about progress notes, you'll notice that we need to have, is there progress being made by that service, and we also note this on recovery plans, what progress is being made, and if there is no progress being made, what's the barrier? What's present? Why is it not working? Maybe it isn't the right service. Maybe there's other barriers that are preventing progress from being made, and then we really need to be addressing that at this time. Observations of changes in activity level and physical, cognitive, emotional status. Again, I talked about how that comprehensive assessment is updated every 6 months. That would be part of that. Case conference and case consultation notes whenever we have recovery team meetings. Everybody's doing a note, and we're talking, each person is talking from their point of view and what they bring to the team. So, how you as a provider work with that team and how is that affecting your service for that recipient in that conference or that recovery team note. And, the service facilitator is also doing a whole note about that recovery team meeting. So again, we have documentation across the board at all times. We need a list of current prescription medications. We need current prescription of treatment, which would be signed off by a psychiatrist or a medical physician. Informed consents and releases of information. So if we need to have gather information from outside sources, you do a release of information, and that would need to be in the chart. And an informed consent says you have agreed to these services and you understand the benefits as well as the possible difficulties because of this. And then obviously a discharge summary when someone graduates from the program would need to be in that chart. Next slide. So we'll get into this a lot more this afternoon, but our progress notes are really important as we are providing services and as we are having contact with recipients. And there are certain things that we'll talk about again this afternoon that MA says we must have on our chart, on our notes. And there are some other things that are important because they're going to help us tell that story of the good work that we're all doing. And we'll get into that more this afternoon, but many of these things that are listed on this slide really are about what MA must have on that note. And then some of it in the narrative is really about how we're going to tell that story of the good work we're doing. So let's go to the next slide. So billable service. So when we start talking about billable services, recognize there are 14 different service areas within a service array, and we can get in, for the majority of people, it's individual skills development, wellness management. For some folks, it's providing psychotherapy. Those tend to be the main ones that are being used. There's some for assessments, etc. But we have 14 different areas that can be used. As a service facilitator is writing up a plan, part of that plan is writing in what is the service array that you fall under for the service that you're providing, and then you would attach that to your billing. Services need to be provided either individually or in group settings, and certain services have to be provided under CCS, so that they can't really be just done outside of the teaming process. And those are outpatient psychotherapy and adult mental health day treatment services, which is providing providing mental health services, but they're really there all day. We'll move on to the next slide. So what makes a service billable under CCS? They meet an identified need on the assessment. They meet medical necessity. So we're back to that psychosocial rehabilitation. Is this medically necessary that allows for us to bill for that service? The service must be listed on the recovery plan and documented accordingly. So we can't no service can be provided unless it's on that plan and must be included in the service array. So and the other piece to this is that when we provide that service, it must fit under the amount of hours that are written into the plan. So if somebody wrote into the plan that you will meet once a week, or if the team agrees that it's written into the plan, you'll meet once a week for 1 hour, that's what you're authorized to do, and that's what you're authorized then to provide that service for. Going outside of that time, you're no longer authorized, and that's where we get into some billing issues. The service must be provided to the CCS recipient. So we can't do a service that is not benefiting the recipient, and it must be provided with the recipient. And this often we get into some issues around defining who the recipient is. But in the most part, our service facilitators know how to handle that and know whether they're writing that plan with each provider included to make sure that you are written in appropriately. And again, I praised our service facilitators earlier. They really do know what they're doing with this. We'll go to the next one. Medical necessity. So if we look at this slide and we start talking about medical necessity, it means under medical, under what MA says, it's required to prevent, identify, or treat a recipient's illness, injury, or disability and meets the following standards. Is consistent with the recipient's symptoms or with prevention, diagnosis, and treatment of the recipient's illness or injury or disability. Is provided consistent with standards of acceptable quality of care applicable to the type of service, the type of provider, and the setting in which the service is provided. Is appropriate with regard to general acceptable standards of medical practice. Is not medically contradicted with regards to the recipient's diagnosis, the recipient's symptoms, or other medically necessary services being provided to the recipient. Basically, when I talk about MHPs and they have to review, part of what they're having to do is to make sure, is that service that we being offered to the recipient, are they meeting these standards for medical necessity? The majority of the time, that's not an issue. But this is really, I present this to all our providers and to those understanding CCS, that when we talk about services, they still have to fall within this definition of medical necessity to make sure that we are providing services within those guidelines of what MA is giving us, since they're 100% funding this program. Move to the next slide. Medical necessity is of a proven medical value or usefulness and consistent with the DHS and not an experimental in nature, does not duplicate with respect to other services being provided to the recipient. So one of the things that we often, MHP has to look for is, are we providing the same service twice? Well, if that's the case, under medical necessity, we really shouldn't be doing that. So if we had two different mentors on the plan doing the same thing, that's where we could get into some difficulties. It's not solely for the convenience of the recipient and the recipient's family or a provider. So is this medically necessary? So again, we're not just providing a service so that the family can continue to go to work, because that's basically, MA would consider that babysitting services, and they're not going to pay for that. With respect to the prior authorization of the service and or prospective coverage determinations made by the department in a cost-effective compared to the alternative medically necessary services, which is reasonably acceptable to the recipient. Again, we're talking about kind of that cost effectiveness. And if you as a provider are providing this service and we can show, yes, we're making progress and it's cost effective because so-and-so would have more difficulties without this, then I think we have at least a fighting chance. And again, these are things that the MHPs are looking at and having to think about as they look at services and make determinations about what they're willing to sign off on and what they aren't. Let's go to the next slide. So if we take all those fancy words and we boil it down, it's basically this slide. Are we doing the right thing at the right time for the right reason? Are we addressing a functional impairment that negatively affects a major area of their life? So are we really addressing one of the problems? Is it, is the diagnosis covered? And are the services that we're providing, will they benefit the recipient? And are our services and that standard of service and quality going to be such that's going to benefit that recipient? Are we really doing the right thing at the right time? Is this really that service addressing what that recipient needs, then I think we can make an argument for medical necessity. We do have to keep in mind the fancy words of the last few slides, but if we're doing the right thing and we're doing it in a way that is cost effective, I don't think we ever run into a problem with medical assistance. Next slide. Travel time. Travel is kind of an ever-evolving issue with CCS. Basically, CCS is going to cover you from your office or your home to a recipient, whichever is shorter, and from that recipient back to your office or home, whichever is shorter. So the amount of miles and time, they're going to pay for the time, but they need the miles also on the written down as to why, to cover. If the recipient is in your car because of you're traveling with the recipient, that cannot be counted as travel time. That either has to be face-to-face service time or it's non-billable. So that's really the basics of travel. So when CCS was developed, it was allowed to pay for people to get to recipients to provide services at where the recipient's at, but they put some parameters around it. And so that's kind of what we have at this point. Now, if you're traveling to a recovery team meeting, that travel can be added in as a billable time. Travel to a non-billable, let's say you traveled to a recipient and then the service never happened. The recipient wasn't there. Unfortunately, then that travel is non-billable as well. And those are kind of the rules that we have with MA around travel within CCS. And I will say that travel is always an ever-evolving issue within CCS, and so as it evolves, we always try to keep you updated on it. Within the last year or so, they wanted to also have other things added to the notes, which we'll talk about later. But in terms of just your basic, what is billable, what is it for travel, we just went over that. Let's go to the next slide. So non-billable services, rescheduling appointments, arranging transportation, collateral contacts. Collateral means, for the most part, getting information or contacting someone who is not the recipient. And then, of course, service updates to service facilitators. So as a provider, if you contacted a service facilitator and had a phone conversation with them, that is not a billable service. Next slide. Non-covered services, intensive in-home mental health or substance use treatment for children. Day treatment for children is not a CCS covered service. Crisis intervention benefits. CSP and targeted case management, TCM is targeted case management, is not covered under CCS. Narcotic treatment would not be covered under CCS. Non-emergency medical transport, again, not covered under CCS. Services to members who reside in residential care centers are not covered. Autism, developmental disorders, learning disorders, respite care, sheltered workshops, again, that's not a CCS covered services. We don't, activities related to finding a member a specific job. Well, we have providers who aid folks in finding work, but if you were just looking for a job and that's all you were providing them, then that probably that is not covered. If you're a provider who is doing job coaching, then yes, that is a provided service. OWI, our assessments are not covered, legal advocacy, and any service that appears to be recreational in nature will not be covered. And we'll get into this a little bit more in the notes this afternoon. And again, this is why it's so important for us to really write good notes that make sense, because sometimes a service can look like you're just doing a recreation. I'm thinking like if a mentor was working with someone who then said, well, I took him to a football game. Okay, well, that I have no idea why, and that looks like a recreational, so that would be non-billable. Now, that might have been a part of the service or the intervention being done, but if it's not documented well and it just looks like it's recreation, it's not going to be billable. Let's go to the next slide. Our billing process is pretty simple. You will do your progress note. They get submitted. I don't know too many that are submitting them weekly, but our invoices get submitted often with those progress notes. We do 100% review of our and auditing of all progress notes and invoices. If they get approved, then the payment is rendered to the provider once approved, and then our notes are scanned into the service recipient record. If they aren't approved, well, let's go to the next slide. So let's do this. Billing requirements. Internal and external staff are assigned a practitioner category with the designates the billing degree. Again, that's based on your licensure or lack thereof. CCS services time is bundled by a degree and date of service. So what happens is they take, we send in bundles of notes or bundles of billing all at once. And so if your notes are late, that can postpone billing. And then those minutes of a provided same degree staff, same date are added together and rounded up. And that's how, basically, we're giving you the ins and outs of how accounts receivable does their billing. But so anybody who is a paraprofessional, they bill all your time together for the month of March. So whether you are a paraprofessional for agency A, B, or C, as long as you're a paraprofessional, that's how it's billed together. We'll go to the next slide. So all billing, obviously, is provided, or let me just, sorry, my computer just went blank, so now I got to pull her back up. So all billing must be completed by the staff for the month before the bundle can be compiled. In other words, it's really important to make sure that you get your notes in on a timely basis, because we can't do our billing without everybody getting their notes in. And as I described earlier, because we're bundling it, if you're late on those notes, it kind of can follow up the process of getting everyone paid. And that travel time is billed separately, but it's billed, and you'll see later in your notes training how it gets on our note as well as in our billing that we turn into accounts receivable. But again, it's the most important part of any of these slides really is that you have to be timely with notes because of how we bill. So because everything is bundled together. so that we can send out the payment to the providers. But you're all based on being timely with your notes so everybody gets paid on time. Let's go to the next slide. So CCS is a cost reimbursed program. MA pays 100% of CCS costs. So your documentation of direct service recipient time and program support time are used in the cost reconciliation process. So the better your data is, and the better you're at providing that and timeliness of getting that information, it allows us as a program to report to the state and federal government how this is working and what's needed moving forward, so that we can make good decisions about this program and its growth. So even though sometimes I think people, kind of like, wow, I don't know, St. Croix County really helps away on our billing or on our notes. We really do, because it's super important for the growth of this program and for us moving forward with the partners who are funding this program. And so I can't emphasize enough how important it is when we talk about billing that everybody is timely with it and that they're doing notes and progress notes to the best of their abilities to meet the requirements of what we need. So let's go to the next slide. So remember, not only is documentation important because it's insured, it's also important because it's going to tell the story of that recovery, and it's the proof that the service you're providing is needed and can be billed for. So I've mentioned being audited by MA. MA will audit at all records at some point, and most of the time when they ask for money to be paid back, it's due to insufficient or total lack of documentation. And this includes your provider's signature. So we'll talk about this later this afternoon. There are certain things that have to be on that, and we will always be checking to make sure that they are there. So as it was stated by one MA auditor at one point, if we don't see it, you didn't do it. We'll go to the next slide. So do you have any questions about our CCS 101 program? Be a good time to ask them now. I know I threw a lot of information at you, and we did it rather quickly, and it's kind of a new experience for us doing this virtually, because often you can't really be able to have that back and forth that we can when we do it face-to-face, but as we know, we can't be doing it face-to-face at this time. So again, if anybody have any questions, please ask them or text them to Adam, and I'll do my best to answer them. Adam, are we getting any questions?
I am not seeing any.
Well, if that's the case, well then let's do this. If everybody would be willing, and Adam, I should ask Adam if this is okay. If everybody, could everybody send you an email, their email where we can send their certificate of doing CCS 101?
Yes, and I think
so that we can get it mailed out to them.
Yeah. So I think what I'll do is, why don't we kind of formally end? You can close out however you want, and then I'll just ask everybody to stay on for another minute or two while I give you the instructions on how to do that, because we're going to post this for others to see that couldn't attend. And
okay, sounds like a plan.
I don't want confusion and
Right.
if there's overlapping instructions or anything like that.
So I'll make one last ask if anyone has any questions. Otherwise, we'll end for now, and we'll meet back together at 1 o'clock this afternoon, and we'll do our notes training. So again, any questions? If not, we'll end it. I'll give you one last call. Okay. Well, let's end this training, and then Adam, let's get you give them the instructions on how they can send you their email address so we can directly get them their certificate for being involved in CCS 101 and their training hours for it.